Endoscopic resection of large duodenal and papillary lateral spreading lesions is clinically and economically advantageous compared with surgery. Introduction. Sporadic, non-invasive adenomas of the duodenum and ampulla are uncommon. They are most commonly found in the second part of duodenum, and estimated prevalence rates of 0.02% to 0.5% have been reported in autopsy series. Duodenal adenomas and papillary adenomas follow the stepwise adenoma-carcinoma pathway, similarly to colonic neoplasms, and removal is therefore indicated. Today, duodenal adenomas and papillary adenomas are often diagnosed incidentally at an asymptomatic stage during esophageal-gastroduodenoscopy or endoscopic retrograde cholangiopancreatography (ERCP) performed for other indications. Most duodenal and papillary adenomas are small, less than 20 millimeters. For such lesions, endoscopic resection affords very good outcomes with a favorable safety profile and is well supported by systematic study. A subgroup of lesions are large laterally spreading lesions of the duodenum or papilla, LSL-D/P. These lesions are greater than or equal to 25 millimeters in size, and when involving the papilla, they generally extend greater than 10 millimeters beyond the papillary mound onto the duodenal wall. Few systematic data are available on the endoscopic management and outcomes of this subgroup, and such lesions are often managed surgically despite substantial morbidity, 30% to 40%, and mortality, 1% to 4%, associated with surgical resection in this unique anatomical location. Limited retrospective data suggest that endoscopic resection of duodenal and papillary adenomas may offer a superior safety profile compared with surgical resection without significantly compromising long-term outcomes. However, cohorts are heterogeneous in both patient, lesion, and procedure characteristics, and few have sufficient power, which makes interpretation of the data difficult. Which of these approaches is superior is currently unknown, and as the entity is relatively uncommon, a randomized controlled trial is extremely unlikely. Thus, the best information is likely to be obtained by modeling. In the current study, we aimed to compare actual endoscopic outcomes and costs of patients undergoing endoscopic resection of large laterally spreading lesions of the duodenum or papilla with the expected outcomes and cost of a hypothetical surgery using validated clinical prediction tools. Background and study aims. Adenomas of the duodenum and ampulla are uncommon. For lesions less than or equal to 20 millimeters in size and confined to the papillary mound, endoscopic resection is well supported by systematic study. However, for large, laterally spreading lesions of the duodenum or papilla, surgery is often performed despite substantial associated morbidity and mortality. Klein et al. Aimed to compare actual endoscopic outcomes of such lesions and costs with those predicted for surgery using validated prediction tools. Patients and methods. Patients who underwent endoscopic resection of large, laterally spreading lesions of the duodenum or papilla were analyzed. 2 surgeons assigned the hypothetical surgical management, the National Surgical Quality Improvement Program, NSQIP, and the Portsmouth Physiological and Operative Severity Score for the Enumeration of Mortality and Morbidity, PPOSSUM, were used to predict morbidity, mortality, and length of hospital stay. Actual endoscopic and hypothetical surgical outcomes and costs were compared. Results. A total of 102 lesions were evaluated. Mean age of patients 69 years, 52% male, mean lesion size 40 millimeters. Complete endoscopic resection was achieved in 93.1% at the index procedure. Endoscopic adverse events occurred in 18.6%. Recurrence at first surveillance endoscopy was seen in 17.7%. For patients with greater than or equal to 2 surveillance endoscopies, 90% were clear of disease and considered cured, median follow-up 27 months. Compared with hypothetical surgical resection, endoscopic resection had less morbidity, 18% versus 31%, and shorter hospital stay, median 1 versus 4.75 days, and was less costly than surgery, mean $11,093 versus $19,358. Conclusion. In experienced centers, even extensive, large, laterally spreading lesions of the duodenum or papilla can be managed endoscopically with favorable morbidity and mortality profiles and reduced costs compared with surgery.